I'm Dr. Zara from Moradabad. I want to ask a question, practical question regarding infertility. Some patients complain of galactorrhea. On examination it is present, but their prolactin reports come normal. So what we should do for these patients? Should they be treated, or we should ignore this clinical?
So once you get galactorrhea, clinical galactorrhea positive, you should repeat the serum prolactin. You can do the pooled prolactin, not the single prolactin, because galactorrhea is persisting. The verdict is divided, but I normally put them on bromocriptine. I do treat them once I get the such type of galactorrheas. Many people leave it. But for IVF, I don't want to take any chance. I do try to treat them. That's always a good option for me.
To which extent you reduce it? Up to which extent you reduce it?
To?
Up to which level?
In case the prolactin is...
duration and dose?
No, we normally give it till the time we are doing the IVF, no? After that, IVF says stop.
You always keep below 25? What is the level?
We have to go by the norms of the laboratory. The norms of the laboratory, they have got some particular values. Every laboratory has got different, like vitamin D, you will have different values from different labs, like FSH, different values of the lab. So whichever lab you follow, we have to keep it under control. I feel that we should keep it under control. And in case it is normal already, if it is already normal and still she is having galactorrhea, the choice is sometimes we tend to not to give it. But when we are doing an IVF, I want to give a cover of the drug so that I don't miss out something.
What is the usual dose, sir?
Usual dose of, we are giving cabergoline. We can give cabergoline. Give 0.25 milligram tablet weekly. We give cabergoline. Bromocriptine nowadays we don't use, so we are using more of cabergoline.
Yes.
And cabergoline as such we were using for anyone who is who can have ovarian hyperstimulation. We give cabergoline to large number of people. So cabergoline can be given empirically also, as we give empirically. So we can give it here also.
And when you discontinue, sir?
After the day after the pregnancy comes positive, the day we get a beta Hg positive, we discontinue. We don't continue thereafter. Maximum wait is till heartbeat or 10 weeks, then we discontinue.
At 10 weeks of pregnancy?
Pregnancy. I normally discontinue at heartbeat. Some people go till 10 weeks of pregnancy, but I continue at sharp 7 to 8 weeks. The heartbeat comes at around 7 weeks, then I discontinue. But you have to keep follow-up of why is prolactin high. I mean, starting empirically, so it's a microadenoma or a macroadenoma, it's a big prolactin. You have to keep a tab on that. It's not that you are getting a prolactin value high and you start the treatment. You have to find out the cause. Maybe you'll have to, maybe some people may even require an X-ray of sella turcica. Some people may require a higher advanced investigation. Maybe they require a fundoscopy. You have to find out why the prolactin is coming and how high is it. You just can't start empirically. In her case, she said prolactin was normal.
Yes.
And galactorrhea was there. I said empirically I like to give it. But the verdict can be divided. But when you get prolactin high, you have to find out why are you getting high prolactin. You have to do that first. Then you have to treat. So something can be treated with drugs, sometimes you need a surgery. So it's a microadenoma or a macroadenoma, or there can be a pituitary tumor at some point of time, or a stalk compression. So we have to be very careful about this thing.
So what is the role of monitoring prolactin level in male infertility?
Okay, so prolactin levels in the male infertility, we don't monitor. We don't monitor prolactin levels in the male infertility. We only do prolactin measurements when we are suspecting a patient to be having hypo. So when someone has got, it's a very good question. It's more common than what you said. Because normally, aajkal we don't look at galactorrhea. In a woman, we don't look for galactorrhea. We do carry out prolactin.
Yes.
So examining somebody's breast without having high prolactin is not what we routinely do. Are you doing breast examination for every woman coming to you?
Yes.
So we ask for galactorrhea.
So we have stopped. We have stopped nowadays. But doing it, but we should examine everyone's breast. Somebody should examine. That is a part of. So breast examination you can do. But for
fertility.
not as a fertility, that's what I'm trying to say. But what second question is more relevant to us, because in which case we should be looking for prolactin in the male. Pretty important. When somebody has got hypo. Now what is hypo? Hypo means hypogonadotropic hypogonadism. So basically we are dealing with a male who is having hypogonadism. What is hypogonadism? When the levels of testosterone are less than a particular cutoff value, which is given in nanograms per deciliter. When the cause of hypogonadism can be many. It can be either the failure of testes, tabhi you will have hypo. It can be due to the failure of the pituitary gland. In that case, it will be hypogonadotropic hypogonadism. Or it can be hypergonadotropic hypogonadism. But end point is we'll never have hypergonadism. We have hypogonadism. A male at 35-40 can also have hypogonadism. So hypogonadism we don't cover for C3, we cover for C2. 3 to 4 hours, 5 hours nowadays spending on hypogonadism for C2 batches. In your batch probably we may not have done it, but now we are evolving into hypogonadism. Now males can have hypogonadism, either they say there's a problem hypo and hypo, or hyper or testes they become smaller. If somebody's testes they become smaller, which we normally check by using this particular device, Paredes orchidometer. I don't know whether it's C3 batch we don't talk about this, but C2 batch yes. So testes become smaller in a male, then it is hypogonadism. And large number of men, they can have non-reacting testosterone. The body has got testosterone, but that is not properly functioning. Many people have got low FSH. When they have got low FSH, the levels of testosterone are also low. So main problem is with hypogonadism nowadays in the male. So large number of men are hypogonad. So when do we do prolactin? We do when we have got hypo. We don't carry out prolactin in any other male until we suspect hypogonadotropic hypogonadism, because that's the time we feel that there is secondary hypogonadism. We have got pituitary stalk compression. Then we do prolactin. But prolactin is not routinely to be done for the man. Yes, for the man who have got some amount of male sexual dysfunction, there we carry out serum prolactin levels, because they can lead to erectile dysfunction.